Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friend. Welcome to this week's episode of the Healing Pain Podcast. On today's episode, we're discussing the intersection of disability, inclusion, and justice. Today's episode is number 310. I want to thank all of you who have followed along for the continuing weeks and months and years with the Healing Pain Podcast. Hey, if you like what you hear and you enjoy our guests, make sure to hop on over to iTunes and give us a 5-star review and share this episode with your friends and family. That really helps us reach more people and deliver a message of hope and healing for the millions of people with chronic pain and disability. My guest today is Dr. Winston Kennedy. Dr. Kennedy is a physical therapist and also holds a master's degree in public health, as well as a PhD in kinesiology, with a concentration on adapted physical activity. Dr. Kennedy is currently a postdoctoral fellow at the University of Massachusetts Chan Medical School, where he is committed to conducting research that supports the health and well-being of people with disabilities and their intersecting identities. Some of his current research includes how physical activity interventions accommodate youth with psychiatric and intellectual developmental disabilities. Dr. Kennedy is also interested in understanding and ultimately influencing healthcare professional curricula in order to train health professionals to work with and better support people with disabilities. On today's episode, we discuss disability justice and inclusion and what it has to do with physical therapy, how we should conceptualize or reconceptualize disability, what healthcare providers can do to support clients with disabilities both in and outside of the clinical practice setting, and the topic of intersectionality and how it relates to disability justice. Okay, without further ado, let's begin and let's meet Dr. Winston Kennedy. Hey there, Winston. Welcome. It's great to have you on this week.
Hey, happy to be a part of the show.
I'm excited to talk to you. People just listen to your bio, of course. They have a flavor of the things you're about, but when you kind of really start to dig into your DPT education and your master's in public health, and obviously you're pursuing some postdoctoral work now and teaching, you have a large body of work that's pointing toward disability advocacy and social justice, which is not common in physical therapy, really. Mm-hmm. So it's great to speak with someone about these topics, which I think are growing. They're definitely more of our awareness, but we want to obviously raise more awareness around it. Tell me how you got started in this.
Definitely. So it actually started when I was working in the clinic. I graduated 2015. So from 2015 to about 2017, working full time, and I worked hospital outpatient for a lot of that time. And I had patients who had chronic neurological disorders, and they were asking me, I want to be more physically active outside of rehab, and I had no answer for them. They had a couple of places, but they cost a lot, and there were some barriers. So I kind of wanted to investigate, how can we be better at this? And that led me to getting a PhD in kinesiology at Oregon State University. And the concentration of the program was adaptive physical activity. So the emphasis was on providing access to physical activity for youth, across the lifespan for people with disabilities. And that's what really got me grounded in, disability studies, public health promotion. And it kind of just started snowballing from there. And I was like, well, this is great information. This would be great to have in physical therapy. So that's when I started kind of trying to build that bridge of thinking about, disability less in a medical context and more in a cultural context. Because, there's room for both, right? Mm-hmm. And, and that's how I just kind of got rolling.
So explain that to us. So disability, so looking at disability as a medical condition, so to speak, or looking at disability as a social construct, if I heard you correctly. Is that right?
More like a dimension of culture from a cultural lens.
Tell us about that.
Yeah. So, in PT, we learn about how to treat the individual, and they usually come with a medical diagnosis. PTs don't treat medical diagnoses, right? But when we hear those diagnoses, it kind of gives us a picture in our mind, right? And, that's kind of the unofficial way we kind of go about, treating, some of our patients. And what that does, it kind of overemphasizes that medical aspect, and then that kind of leads you to talking about, limitations, deficits, there's an emphasis on, what someone can't do, right? And, when you shift to that cultural perspective, it's kind of looking at disability as more of an identity of the individual. So you're not so focused on their limitations. You're more focused on who this individual is and kind of what they want to get from coming to you as a physical therapist. Mm. And that's so different, kind of can really impact how you go about, implementing your plan of care, right?
Absolutely. So less on the, I guess, normalizing impairments, right?
Yeah.
Even that word normalizing is probably a little tricky, right?
Yeah. And even the term impairments is also tricky as well.
Yeah.
Because it's kind of based on a normative standard, like, able-bodied individuals like you and me.
Right. Which, the reason why I use normalizing impairments is because the idea that there's one body type that's ideal has a lot of challenges and problems that go along with it, especially for the disability community.
Yeah.
So not normalizing impairments, but looking at identity. So identity is a really interesting word because that really starts to place care a little more in the psychosocial realm. So what you're saying is there may be a change of identity status as someone is going through their rehabilitation process, or because of an injury potentially.
Oh, definitely. For a lot of us, when we have an injury or, we come in contact with, a disorder or disease, it changes the way we do a lot of things, how we interact with our physical environment and how we interact with our social environment, right? For example, even from just living with your family, roles change, maybe your status or role in the family's changed. And, dealing with that on top of going to rehabilitation, you probably have medical doctor's visits, it's a lot to kind of take in and to do. And, sometimes, always we should take that into account in PT, but do we always?
I think the answer is no, right?
Yeah, I would say that. Yeah, but I'm trying to be nice to our profession. We're coming along.
Yeah, I'm trying to imagine what this conversation looks like to maybe someone who's not so aware of the idea of, there's more. I have more skills than just addressing an impairment. And what does that look like? How do I, as a physical therapist, impact someone's social identity, right?
A lot of it has to do with kind of being open, and kind of letting who you're working with guide you through that. And I'll be honest, it's harder than it sounds. Let's, be honest. And I'll be honest. And, oftentimes we don't always get it right. A lot of our aforementioned beliefs or things we kind of, grew up understanding or seeing kind of sometimes even implicitly comes up. Right. And I believe the biggest thing is, keeping an open mind. Right. And we have as physical therapists, we have the tools and the knowledge to implement a plan of care. I also believe we have the tools to adapt our plan of care based on the needs of, our patients. And oftentimes that means instead of me coming up with a goal of, you walking, 500 feet, it might be, the participant tells me, I need to be able to get out of bed and go to the bathroom. I can use my wheelchair in any other space or for mobility, instead of saying, we can just get you to walk, or we can just keep trying to walk. When my patient says, I just want to be able to walk to the bathroom and I can use my wheelchair, then okay, we can do that. And if that changes, then we can, accommodate and change with that. But to kind of push, perspectives from having an able body and even project that, or even just considering what someone used to be able to do and trying to, I would say, overemphasize you doing it the exact same way that you did before.
Mm-hmm.
That's even from, an acute orthopedic injury. Things might have to change, mechanics might have to change, and that's okay.
Yeah, it makes me think there's a difference between rehabilitation and recovery, so to speak.
Definitely.
Rehabilitation is almost like that kind of older process of here's what we do to people.
Mm-hmm.
They're coming into a rehabilitation center, so to speak.
Mm-hmm.
And here's the process that we take you through when you come into our facility.
Yeah.
Versus recovery really is more you, the person who is interested in recovery. It sounds like you're saying is the one who sets the plan.
I would say the person who's in recovery is leading the plan rather than creating it. Right. So that means, it is my primary goal, and is it possible to, for example, get back to walking? And if that's a stated goal, and as a PT, it's a possibility and I can support that, no issue. The reverse is, I want to be able to use my wheelchair in different environments, on different surfaces, and I would like that to be my primary mode of mobility. And as a PT, I can support that versus you used to walk, we want to get you back to walking.
Right.
Right. And a lot of it is just alignment between, my patient and the PT, and even if, the patient is not aware of the possibility to walk, and and you foresee in your prognosis that this is a possibility, I don't think it's wrong to say, we can work towards that. But there may come a time where you say, we need to also focus on, wheelchair mobility or an assisted device in some manner. And there is no one better way. The only better way is what's more comfortable and feasible for you. Mm-hmm. Right. So there's a way to kind of do a lot of different things, but also being aware of the individual, what they need and what they're telling you they want,
A lot of your research focuses on looking at what's happening within our profession, the profession of physical therapy. How does disability justice and inclusion, what does it have to do with physical therapy per se?
Well, definitely. It has a lot to do with the advocacy side of what we do. And that stems from advocating for assistive devices for our patients, advocating for different services for our patients. And those services can range from, trying to help get increased support in the home, right? Return to work, helping support the need for accommodations at work, all those things, right? And outside of a disability justice lens, we might not think that we are as important on the advocacy side, right? Because, we see our role as in the clinic, treating what we need to treat. And, after our patient gets discharged, out of my hands, I might do a follow-up call. But that's pretty much it. As PTs, our knowledge and expertise kind of extends beyond that. Right. And we need to, we need to be better at just acknowledging that generally, but specifically on the disability justice side, because a lot of times we're one of the first point of contacts. And we spend a lot of time, inpatient rehab, skilled nursing facility, 75 minutes, 90 minutes, about volume, and you're getting to know your patient, they're telling you all these things. And that information gives you the ability to say, hey, my patient needs this. This is their living situation. This is the support they had. And I agree. And they're telling me they need these additional supports. So let's go out and do it. And that's even, partnering with other professionals, MDs, nurses, caseworkers, case managers.
I feel like if you look back on our profession to the 60s, 70s, maybe 80s, it seemed like there was more of a focus on disabilities within our profession. And I think as we grew and we now have a lot more outpatient facilities, and physical therapy really has become, a dominant force in the outpatient world. I wonder if that's changed, like if we as a profession have changed. So I'm just wondering, where do you think we are as a profession as far as supporting people with disabilities, let's say.
Definitely. And I'm happy you brought that up. One, because I didn't think about it, but we all know, outpatient ortho, that's the dominant setting and specialty in PT, right? And so that dominant domain is going to get a lot of visibility and a lot of support, and so that shift kind of may have took us away from maybe some of the things that we were doing that we're probably not doing anymore, right? And as a profession as a whole, I think we're starting to realize and get back to the level of awareness that we probably had in the past. But it's a kind of a slow grind. It's a real slow grind. The APTA just passed a motion supporting physical therapists with disabilities through providing resources and accommodation, which is wonderful, right? But there wasn't really an action plan behind that. It was, just lip service. To an extent, it stops becoming lip service when there's actionable items afterwards.
Supporting physical therapists who themselves have a disability.
Disabilities. Yeah. And that's a whole other area that we're just now starting to begin talking about. And other health professionals are farther ahead than us. We see a lot of work with medical doctors and trying to support medical doctors with disabilities in their profession. Same with nursing. And there isn't anything, both from a scholarship perspective or just, at professional organizations on the bulk of trying to support our colleagues with disabilities. And this past year at CSM, you started to see a little bit more of that, but, a lot of it needs to be more, because right now we don't know how many PTs with disabilities there are. Another side of that, and a big part of the disability justice lens, is creating a safe space for you to disclose that. And a lot of PTs don't feel safe disclosing that for a lot of reasons.
When I was at CSM in San Diego this past February, I sat in on a really wonderful lecture on disability justice where physical therapists with disabilities, I'm not sure if you're on that lecture, presented. And, there are people out there like the first physical therapist who was blind, which is really interesting to hear her story of the accommodations that she did receive and the ones that she did not receive, both in school and in her workplace. And then other physical therapists there who had some physical disabilities who lost their job because of it.
Yeah.
And you think to yourself, wow, how can a physical therapist lose their job because they're looking for an accommodation for a disability? Like, we're supposed to be leading the conversation in disability justice. And when that happens, it makes me really concerned.
Exactly. And that's the funny thing. That's pretty much illegal, firing someone for a disability. But I'm sure it's easy to get around that, right? So technically you're not firing someone because of the disability, but you kind of, you make up a reason why you're firing that individual. And that's what's holding a lot of PTs back from disclosing, right?
I know you've done some research on looking at a physical therapist's attitudes and behaviors toward people with disabilities. Can you tell us a little bit about that research?
Yes. One of the first studies I started on when I was doing my PhD was looking at perspectives of physical therapists, occupational therapists towards their attitudes towards disability. So that's been an area of research that's been going on for a while, since like 60s, 70s, which was kind of perplexing because we kind of know that unfavorable attitudes impact health outcomes, right? Because unfavorable attitudes towards disability leads to how you implement your plan of care, how you refer or recommend other treatments. If you're promoting physical activity or not, promoting engaging in recreational activity outside the clinic. So that's a strong research area right now. And again, we're not at the forefront of doing anything about it. Right. So, I've started kind of trying to host continuing education courses going into PT schools and talking about disability from more of a psychosocial cultural perspective. But the goal is for things like that to be embedded in our curriculum. And I don't think that's a heavy lift. Occupational therapists do a great job of including that psychosocial, even cultural aspect, into how they work. And I believe we can do the same. And a lot of it is not even about adjusting the curriculum. A lot of it is honestly adding on to what you're already teaching, right? So, in your orthopedics class, you can work with someone who has a disability who has an orthopedic injury. Are you being taught how to do that? Probably not, right? So, and that goes back to how we form those attitudes and perspectives towards disability, right? One study I did was ask a bunch of kinesiology students how they define disability. We know kinesiology students are likely to go on to health professional positions, physical therapy school and such. So kind of investigating how they see disability gives us an idea of how those perspectives will translate when they go into those health professions. And what we found was that they define disability as an inherently difficult experience. Right, that was one of the major findings. And the issue with that is that's an assumption you're making without having the experience or having someone tell you that's their experience, right? You're just viewing things that if I were in that position, that looks hard and difficult. So things must just be in general hard and difficult for this group of people. And not to say that someone can't have that experience, but the assumption that's the experience for everyone is the issue.
Right. So they may have a difficult time taking a different perspective at that point in their career.
Exactly. So and that can get reinforced in PT school, right? So we have those disability simulations where you're like, go in a wheelchair, blindfold yourself, put on some ear muffs, and then students are like, oh, this is hard. I couldn't do this. Now I sympathize with, this population of people. I understand. But what is happening is you're creating stigma, right? Mm-hmm. You're saying that, an individual who may have been born a certain way or may have acquired a new way of living, and you're saying you within the 5, 10, 15 minutes pretending you kind of now have this great idea of what this is like, right?
Yeah. Stigma and ableism again, right?
Yeah.
And a lot of health professionals have been through those disability simulations. I know I went through one in school.
Me too.
We had to spend a whole day kind of role playing or, picking a disability, if you would. And I know now there's research, as you mentioned, that probably shows that that's not the best way for us to take the perspective of another individual, because as you mentioned, someone could be born a certain way and learn how to effectively cope versus you just all of a sudden, let's say, put a patch over your right eye so it impairs your vision. It doesn't give you a real sense of what it's like to live like that over the life course of someone.
Exactly. 100%. And in other professions, things are shifting to more of, bringing the population of people that you're going to be working with. So if you're having a practice module, and physical therapists can do this too. If you're having a lab, bring in people with this lived experience and, learn from them. Right. And, I think that's doable. There's a lot of disability advocates who would love to get into that space because that helps make their experience better when they interact with other health professionals. So I believe it's doable, but programs have to want to do something like that because there's some work, on the back end.
Yeah. Bringing the lived experience, basically. Bring it into obviously into school, bring it into research, and then it'll be somewhat easier when you first start to work with it in the clinic. For sure. So you mentioned early in the episode that a lot of your work looks around kind of maybe social barriers for people with physical activity. Mm-hmm. Do you have any research, or do you get a sense, or is there an evidence base out there that these social barriers could have an impact on the development or the maintenance of chronic pain?
For chronic pain, I am not so sure. But can you repeat that question?
Yeah. So when we look at, let's say, someone accessing physical activity outside of physical therapy clinic, if they can't access or it's a barrier, does that impact their pain?
Oh, definitely. So what we know about pain, like the huge shift is what biopsychosocial, right? So we know about the physiological aspects of pain, right? As PTs, I think we're less open to the psychosocial aspect of pain, right? And you see that when, say your patient comes in and they're like, oh, I'm a 10 out of 10 pain. Then as a PT, you're like, oh, they're always a 10 out of 10 pain. Why are you not in the hospital? Why, if you were really 10 out of 10, XYZ. And it's more so if this person is telling you 10 out of 10 pain, it's an issue. How can I help with that? Mm-hmm. Do we need to call, the emergency and get an ambulance and take you in? And if they say no, well, I don't have to do that. Do we need to not do treatment today? They say no, they can participate, not relying so much on, that number, but probing more to see what's really happening. Who knows what they could say? They could say, today I had a really bad day. My kid wanted me to pick them up. I have back pain. I couldn't do it. My wife was, I'm telling me to wash dishes, but I couldn't do it because I can't stand too long. And now all these things I remember when I can't do, I have increased pain. And when that pain is invalidated, you step back, you start talking about it. You might disengage from other things you do outside of the clinic, because if you're not getting the validation from a health professional, am I going to get the validation from anyone else? Or even, at a gym, if I'm working with a personal trainer or, things of that nature. And on the other side of that, is my PT helping me, work through the pain, depending on what type of pain it is, right? And, that also has some carryover over to outside of the clinic. Because if I can do these things in the clinic and manage my pain, and I'm learning how to do that on my own, again, it gets transferred. But when you, unable to validate and unable to probe, that leads to a huge social barrier, right? I've had experiences with just that, in skilled nursing facility, they're complaining of pain. The nurse is telling me that, oh, they're lying, right? And then I go in and we have a conversation. I'm like, I'm sorry that happened to you. I understand you're in pain. Would you like to sit up? That might help you feel better. And then all of a sudden we're doing all these things. And the nurses, how did you get them to do that? Well, I listened and I validated and I acknowledged. Mm-hmm. And we worked through it,
And that's the biopsychosocial approach right there, right?
Yeah, 100%.
And sometimes it doesn't take that long. It just takes a couple of moments, as you said, to sit and listen and be with someone as they're really talking about their entire pain experience, not just their exactly. description of the sensation they're experiencing, so to speak. Exactly. Tell us about intersectionality and how it relates to disability justice.
Definitely. So intersectionality basically is considering an individual's identity or several identities and how they basically connect to account for, discrimination, right? So for example, if it's one thing to be Black, it's one thing to have a disability. It's another thing to be a Black person with a disability, right? And similar with, one thing to be Hispanic, one thing to be a woman, one thing to have a disability. It's one thing to be a Hispanic woman with a disability, right? So intersectionality really takes those identities into account and gives us an idea of the discrimination and oppression that might be layered on top of those identities, right? And from a disability justice lens, that really tells us to, even within disability, we can't just look at disability, right? Race, ethnicity, socioeconomic status, culture, right? Language, place of origin, all these things really kind of can tell us, well, not tell us, but give us an idea of an individual experience. And the second part of that is basically taking that idea, not projecting it, but just using it as a guide to listen to who you're talking to, right? So, as a Black man, a lot of people might assume what my experience is, right? And again, it's okay to think you have an idea. There's a lot of social media, it's a lot of things we're learning about a lot of people's experience. But on the other side, do you know me, right? So don't just assume that experience, that happens to Black people is automatically happening to me, right? You can ask me a question versus, oh, I'm so sorry for, the police brutality. And I'm like, well, I am fortunate enough to not have experienced that type of police brutality. So why are you bringing this up to me, right? And it's those type of things that'll make anyone feel uncomfortable, much less if you're not a majority in a particular group, right? You feel, and I've experienced this myself. You feel, singled out, even if it's in a positive way, or in what someone intends to be positive, right? But if I'm in a room and I'm the only individual like myself, I don't want you to just call on me because we're talking about something that relates to myself, right? Or people who are like me. If I raise my hand and want to give my input, sure. But, pointing your finger and be like, you tell us, is, not the best way to go about it.
It's a nice little microaggression, right?
Oh, yeah. Oh, yeah. Oh, yeah. What do they say? Microaggressions like 1,000 paper cuts.
Yeah.
Right. Just getting at you.
So you mentioned in that description the word oppression, which no one has probably, or maybe one person, probably no one has brought up on this podcast. I've done over almost 400 episodes now at this point. Oppression is a word that people relate to a lot of different things. So how do those overlapping intersections that you're talking about, I guess you're saying that they layer on oppression and then that impacts someone's lived experience? Yes,
definitely. And by oppression, I mean exclusionary practices, right? Lack of accessibility, right? A decreased sense of belonging, right? So basically being an outsider and being told you're an outsider and being treated as an outsider, right? And that leads to oppression, because if you're seen as an outsider, will I have policy that supports you? No. Will I have, procedures and practices that support you? No. If I'm thinking about, it's even from building, if I'm thinking about creating a building for, a certain group of people, right? Am I thinking about an outsider? No, right? So that decreased accessibility. I can't do that. I can't be a part of society like I need to. I can't function in society like I need to, right? And a lot of people and a lot of groups, in this country, feel that. And then it gets layered and layered and layered through that intersectionality perspective.
A lot of these sound like they're assumptions to a certain extent. People make assumptions about what someone's experience is based on maybe what they see, or what they momentarily hear. Like, if you don't mind me using you, for example, I was reading up in your bio. So, for example, you were a football player at one point. So you're a strong male football player. If you came into my clinic and I made the assumption that, well, since you played football and you're relatively, tall and somewhat husky, so to speak, that you have a higher pain tolerance than other people.
Yes.
And that also, of course, gets wrapped up into race and sex and gender, et cetera, et cetera.
Exactly. I think I've seen a study somewhere where I think physicians reported there was a disconnect between like what they reported as a Black woman being in pain, and it was way different. They basically said that Black people, and I think this was on Black women, just inherently have like a higher pain tolerance. And so when they report on pain, they're less likely to prescribe medications because they believe they don't need it. And don't quote me on that. Google it yourself, because I haven't seen that study in a while. But from what I remember, that was kind of the gist of it. And we see these, that's basically a trend in healthcare, right? With Black women are 3 times as likely to not survive during a pregnancy. That's a wild concept.
Yeah.
To me.
We've actually talked about that study on the podcast before. We've gone into that study somewhat deep, although I think that conversation needs to be revisited many, many times, because it has a lot of implications for people of color. And as you mentioned, women. People think women, especially if they're pregnant, have a higher pain tolerance, which it's silly. There's not a whole lot of evidence there to support any of that. Winston, I think the work you're doing is great. I think that oppression piece is really powerful for all of us to think about. And I appreciate you leaving that with us. If people want to follow you and your work, how can they learn more about you and keep up to date?
Definitely. Well, I'm not as active on social media as I was, but you can check me out on Instagram. I am the rolling_stone_ THEROLLIN_STONE_. Hopefully I'll get back to that. Also, you can Google the Disability Justice and Anti-Ableist Catalyst Group. We have a page through the Academy of Leadership and Innovation through the APTA. You can Google that and look up my email, contact me for more information on the group. We're hoping to do some great things this coming year. And my email, winston.s.kennedy@gmail. Any questions or any opportunities to just chat, talk about the profession or anything at all, happy for it.
I want to thank Winston for joining us this week on the Healing Pain Podcast to talk about disability advocacy and social justice, both within and outside the physical therapy profession, and for people obviously with disabilities and chronic health conditions like chronic pain. Make sure to share this with your friends and family on Facebook, LinkedIn, Twitter, or Instagram. I'm always on Instagram, just like Winston, so you can find both of us there and tag us and let us know how much you enjoyed this episode. I'm Dr. Joe Tatta. Make sure you download the latest episode by going into your iPhone and choosing the Healing Pain Podcast so you can stay in touch with us each week. I'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativePainScienceInstitute.com. That's integrativePainScienceInstitute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.